Topbed Talk.
The title of my presentation is Prehabilitation, Innovative Models of Care. I'm Dr. Rachael Barlow. I'm Clinical Lead for Prehab to Rehab at Cardiff and Vale Health Board in Wales. The people of Wales are particularly unfit. This slide illustrates the increasing epidemic of obesity, the high incidence of smoking, physical inactivity and alcohol intake amongst our population generally. It's now the time to move away from waiting lists for surgery to a place of preparation lists, getting patients and our population actively participating in preparing for their surgery. We know that certain elements are impact on someone's clinical outcome following treatment. Some of these are modifiable and we can correct these with enough time, such as smoking, alcohol, nutrition and physical inactivity. Some are slightly more challenging to address, such as muscle wasting, fitness and emotional resilience, and addressing comorbidities such as diabetes, hypertension and cardiovascular disease. But with enough time, we can actually make some remedial improvements in these conditions. And this is where prehabilitation comes in, which is around prevention and preparing for treatment. We want to use the time when a patient presents with symptoms of a condition as a teachable moment, making every contact count with the healthcare system, particularly in primary care, to change behaviours. The areas of focus for my session will be 1, the work we're doing around prehabilitation for suspected cancer patients presenting through primary care, and 2, prehabilitation for patients on the inpatient waiting list, and we're using an innovative nudging behavioural change approach. So to start off with then, I want to talk to you about prehabilitation for suspected cancer. We need to improve our cancer outcomes in Wales as the rest of the UK. We have amongst the poorest outcomes of cancer in Europe. And one way that we can do that is by improving the access to curative intent treatments. Prehabilitation can really help with this because we know that some patients who have early stage disease do not undergo curative intent treatment. Then this is indicated by several national audits, such as the National Lung Cancer Audit and the National Esophagogastric Audit, which indicate approximately 50% of patients with early stage disease do not undergo curative intent treatment. Many patients have combined treatments for cancer, working often across organisational boundaries. Patients will undergo neoadjuvant chemotherapy, surgery and potentially adjuvant radiotherapy or chemotherapy. Along this cancer pathway, with patients become increasingly malnourished, their functionality declines, they become increasingly muscle wasted and increasingly frail. The programme that we're proposing, which starts in primary care and works across organisational boundaries, is that prehabilitation flows along the whole cancer pathway and trajectory. Our primary care work was published in a research study in the British Journal of General Practice, Open, and is entitled Fit for Cancer Treatment and is shown on this slide. We had really positive feedback from primary care clinicians regarding this study. One of the GPs concluded that this is something that should be done routinely for all patients. And we're certainly working very actively at the moment in Wales to make that a reality for all patients. We've developed an optimisation bundle which will sit in the primary care health records and the health systems. This is an example and a screenshot of the template. This is the GP example that the GP would complete. And you can see we're only asking the GPs to undertake some routine bloods that would form part of the routine referral. The prime purpose of this is to make sure that the bloods are done in a timely fashion, and then the GP will then suggest the patient presents to the optimisation clinic. That will be pharmacy-led, and you can see an example of the template here on the slide that we'll be producing and conducting from the pharmacy perspective, which includes lifestyle, smoking, alcohol, a previous cancer diagnosis and any treatments, a history of comorbidities and anemia, but also be looking at nutrition, smoking, alcohol, frailty, to name just a few. This slide represents the pathway that we're proposing. So starting the process of optimisation and prehabilitation at the point of referral when the patient presents to their GP, and undertaken the optimisation bundle, undertaken by either a healthcare support worker and the pharmacist. And this will all take place in primary care when the patient's referred into secondary care. Once the patient hits secondary care and has a high suspicion of cancer following a radiological procedure or an endoscopy procedure, we're delivering prehab, community-based prehab for patients to their needs. This will either be anaesthetic-led, exercise physiology-led, allied health professional-led, clinical nurse specialist, and supported by a prehab coordinator. We're working really closely with our dietetic department, physio, frailty, cardiology, haematology for anemia, and our diabetes team, along with psychology, to make sure this is a holistic approach to prevent any delays to treatment and obviously to promote optimisation of the patient. And we're also working very closely with our cancer centres, which in Cardiff is the Vale Cancer Centre, to deliver this work in partnership. So wherever on the care pathway the patient is, they have the most optimal care. The second point I would like to discuss with you is the piece of work we're doing around can we turn waiting lists into preparation lists using prehab style nudge messaging. And this was a concept developed at the outset of COVID-19. When we were aware that elective surgery was going to be postponed by the health minister, we were concerned about the patients on the waiting lists. We know we're going to have a huge backlog of cancelled and delayed procedures, and this is growing week on week. And a 5-year strategy is needed to manage this, and prehab should form a core component of that recovery plan. We know in November 19, so before COVID, our hospital waiting lists were at the worst ever level, and this is outlined in this BBC article. In June this year, so post or during COVID, NHS waiting lists could hit 10 million people per year. So the recovery phase is going to be prolonged, with some patients obviously needing to be on the waiting list for a long period of time. So the purpose of our initiative was to provide self-management advice, educate and support patients during this time about prehabilitation, but also general health and well-being messages. This is to be a dynamic process whilst they wait and hopefully prepare for their elective operations using this nudge approach. The reason why this is so important is that many of our population, about 30%, live with one or more long-term condition. And this equates into about 50% of GP appointments. With patients claiming, about 55% of patients claiming they only feel they have the knowledge, skills and confidence to manage their health. We're targeting all patients over the age of 18 with an open RTT clock. We're excluding cancer patients from the nudging at the initial phase, and also excluding day cases, purely because of the volume and the numbers of patients included in the day case lists. We've worked with our information department to identify all patients on the waiting list, and we've divided those patients into two groups, one with a mobile phone number and those without. The ones with a mobile phone number attached to their health records will receive an SMS text message containing a website link signposting the individual to click on to the UHB website. Patients will then be taken through to our prehab landing page, which will include content to support the prehab agenda. Within that website, they'll also have a specific link to prehab digital content, which will include open videos, online platforms to support the patient with self-management. We will then nudge the patient every 2 to 4 weeks whilst they're on the waiting list with health messages. So this could be simple things like, are you exercising? Have you stopped smoking? Are you eating a healthy diet? We're using focus groups virtually, obviously during COVID, to test this concept with patients and see what patients want to know whilst they're waiting and preparing for treatment. For those without a mobile phone, we will send the information via the post. This is an example of the SMS text message we'll be sending out to patients. And there is an opportunity for patients to respond to this SMS text message directly into our health records department, which will then be prioritised by our patient experience team to the relevant directorate. The number of patients currently on the inpatient waiting list within Cardiff and Vale as of May 2020 was about 3,000 patients. We're keen to understand how this initiative works and does it show any benefit to our population. In the short term, we're looking to receive SMS feedback from patients directly, but also some verbal feedback from patients via the focus groups. We're working with our patient experience teams on patient experience questionnaires, but also working to develop some patient stories to support and refine this work going forward. A simple way of understanding the success of this initiative is to count the number of URL hits on our website, which we're able to do. In the longer term, we're really hoping to be able to work with our communication department to develop a culture change, moving away from waiting lists to preparation lists. And we're working actively with our adjacent health board colleagues to adopt this approach across the whole of Wales. This is a real opportunity to change behaviour for patients who are waiting for elective treatment. We're also working with our primary care and secondary care data colleagues around how we can link data for patients on the inpatient waiting list with their primary care health records. This will allow us to understand our population with the incidence of things like comorbidity, anemia, and actively target groups with relevant nudging messages. We're also very keen, as I say, to understand what our patients want and what our population thinks about moving to a place of preparation as opposed to waiting. And we're hoping all of this can lead to a more sophisticated planning to surgery in the future. So in summary, the two approaches I've discussed are both innovative. They both target potentially hard to reach populations with health messages and lifestyle advice. They're both MDT-led, working closely with primary care, public health, but across into surgical, oncological departments as well. And both approaches offer potentially low-cost, high-value interventions. This is collaborative, working with other health boards, as I say, across Wales, but also we have interest in collaboration from the UK Centre for Perioperative Care to adopt both approaches for rollout across the UK. Thank you very much for listening.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.